A warm welcome to Views on Health. It's a great pleasure to have with me on the program tonight Dr.Kesara Ratnatunga, who is a consultant general and colorectal surgeon at the teaching hospital in Karapitiya. An extra pleasure, I must say, because this is the first time that we're featuring Dr. Kesara Ratnatunga in the series of programs Views on Health. So, Doctor, a warm welcome to you, to our studios, to SLBC, and of course to the program. And I'm sure our listeners are eagerly waiting to hear what you've got to say tonight. And I'm sure listeners will be interested because this is a topic that we have focused on quite some time ago. But according to Dr. Ratnatunga, it is a very common problem and therefore needs to be focused on and addressed accordingly. The topic is hemorrhoids. Without any further ado, over to you, Doctor, to introduce the topic hemorrhoids.
Thank you, Fatima. Good evening to all our listeners. So hemorrhoids, as was mentioned earlier, is a very common problem that many people face. And it's important to understand a little bit of detail about the problem because it's not only because it's a common problem, but because people amongst your family may suffer from it, but may not actually come out with the details of their symptoms. Because hemorrhoids per se can be minor, it can range up to a major problem also, which we will discuss later. But more importantly, hemorrhoids can be mistaken for a more sinister problem. And that is also another topic that I think we should talk about later on in this discussion. Because it has a major impact on a patient's life. So, as I said earlier, hemorrhoids can be just present as a minor irritant, a little bit of blood loss now and then when passing stool, or it can present as a major loss of blood when passing stool and when not, and the patient can even end up anemic and even in a life-threatening situation. So, those are the two extremes. But it's important to recognize the problem, fully assess it, and then also initiate treatment because it is easily treatable. So, before getting on to the details, I think we should understand what a hemorrhoid is. So, a hemorrhoid is actually, it's a normal part of our anatomy. If you take the lower end of the gastrointestinal tract where the stools come out, the rectum and the anus, it's a very complex anatomical structure. And the hemorrhoids form a normal part of it. We call them hemorrhoidal cushions or anal cushions. And it's made up of blood vessels. They form a very subtle, their function is very subtle, and it helps us to distinguish between liquid and solid stool and flatus, enabling us to maintain continence and, to a certain extent, maintain our dignity in public situations. So that's what they do, or they're supposed to do, and the way they work is quite complicated. However, when they become engorged or when they enlarge due to certain reasons, then they present with symptoms, mainly with bleeding when passing stool, and that is usually painless, and also the bleeding is fresh, and it's usually minor bleeding. And this is one of the main reasons that patients don't present early, because they see a little blood, there is no pain, and they would rather hide the fact than tell anybody or seek treatment. The majority, I must say, are asymptomatic, so they have enlarged hemorrhoids but they don't have any symptoms, but bleeding is probably the commonest presentation. The other presentation that we commonly see is that the patient complains of a lump protruding out of the anus, sometimes during the passage of stool, sometimes after, and sometimes even without passing stool, they have a lump at the anal region. And generally this is painless. However, it can become painful when the blood vessels inside get clotted, or we call it thrombosed, which is sort of an extreme presentation. So the vast majority of patients are either asymptomatic, without any problem, or they present with minor symptoms, and that is one of the main reasons that patients with hemorrhoids present late, and then they have a lot of problems with regard to the treatment as well as managing their day-to-day life, and it can be quite problematic to get things under control. So one of the other things that I think we should bring into the discussion at this point is that is it only hemorrhoids that present with these symptoms? Because that leads us on to a broader discussion. So hemorrhoids present, as I said, with bleeding and a lump. And there are other conditions which can present exactly like this, right? Anal fissures is one. It's just a tear in the anal canal, but they also can present with bleeding. But here the difference is that it's painful. Anal fistulae, which is a sort of a communication between the inside and the outside skin. Diverticular disease, which is very common in the West, but not so much in Sri Lanka, but it's becoming commoner because of our diet patterns and the changes in that. Polyps, which are sort of small growths inside the colon. Inflammatory bowel disease, I mean, you may have heard of ulcerative colitis or Crohn's. And the main worry is colorectal cancer. So that also can present with blood in your stool. So if you were to assume that bleeding or a little bit of bleeding is due to hemorrhoids alone, you tend to neglect it, and therefore you can miss a colorectal cancer or a more sinister pathology, which is something that we'll discuss a little later on. So therefore, it's important to understand that hemorrhoids are not the only cause of the symptoms that I mentioned. And therefore, because there are other things, more sinister problems which can cause this pattern, it is therefore important for a proper and systematic assessment by a medical professional to investigate it and to take further action if it is necessary. If it is just hemorrhoids, then the hemorrhoids can be treated. But if you do not look for another problem at the same setting, then you can miss a more sinister pathology, which the treatment and the outcomes can be far more sinister and complicated. So, with regard to hemorrhoids alone, what are the treatment options that we have? So, if to the layperson, hemorrhoids are, because they are common, people tend to ignore it and then present late, and because they are not happy to present to in a general hospital or a public setting, they tend to try home remedies, which is not advisable. Then there are other medical fraternities which will offer treatment, which it's difficult to comment on, but from a Western medical and a scientific perspective, there is a certain series of tests and assessments as well as treatment options that we need to talk about. So if generally you have a hemorrhoid and it is not bleeding or it's not causing you any problem, then a conservative measure, that is not to do any active treatment, but to have lifestyle, dietary, water intake modifications, which will help you to maintain your stool consistency and therefore not allow the hemorrhoid to subside and not progress and then to cause problems. And during that course, if things regress, that's fine. But if it progresses, then you go on to the next stages of management. Then there are multiple options because hemorrhoids have been identified over decades, hundreds of years. It's been known for a long time. There are a multitude of options available, and each of them has its pros and cons. But over a period of time, several methods have become tried and tested. So one of them, or one of the earliest methods, is what we call sclerotherapy, where the hemorrhoids are injected with a chemical. And that chemical causes the blood vessels inside the hemorrhoids to shrink, and therefore the bleeding and the symptoms reduce. These can be done for smaller hemorrhoids. The larger hemorrhoids, it may not work. So therefore, as I said earlier, it is important for a medical professional to assess and see, and therefore decide on the management options. Sclerotherapy can be done in an outpatient setting, even in the clinic. It is painless because the hemorrhoids are located in an area where there are no nerve endings. So the injection can be given painlessly, and generally it is a safe procedure. More recently, one of the treatment options which have become quite well established is hemorrhoidal banding, where a rubber band is placed at the base of the hemorrhoid, and that too is easily done in a clinic setting or as an outpatient, and there again is a painless procedure, and generally the outcomes of those are pretty good. There are some contraindications to that. That means you can't do this in certain patients, patients who are on certain medications because of the bleeding tendencies, if they have allergies to rubber. So those offer certain complications, but it is a sort of freely available and a very good option for managing hemorrhoids, and even the mid-grade ones are okay.
Thank you, Doctor, for introducing the topic and giving us an insight into what the problem is. Now, about when you say it's common, from about what age does this present in people? Are there more women or men, or there's no gender sort of issue in that sense? It can be either.
Yeah, it can be either. And age-wise also, it is a fairly broad spectrum. It is not confined to the younger patient or the older patient, because most of the time the presentation of hemorrhoids or the manifestation of hemorrhoids is because of your toileting habits. So that can change based on regardless of your age. And we see hemorrhoids very commonly in very young patients as well as in elderly patients. Hemorrhoids present quite commonly in patients who are pregnant, because the pressure inside the abdomen is there and they have a lot of congestion in the anorectal region, so they have hemorrhoids, and their symptoms are exacerbated. So that age group and gender, you see hemorrhoids, but generally it's sort of a ubiquitous spread for hemorrhoids.
And also, would you say, Doctor, that basically the onset is because of the bowel movements not being sort of regular, or that's what is the bowel movements that impact on this?
Yes, so it is more than the bowel movement per se. It is the act of straining and the difficulty with which certain people have when passing stool. So, example, if you are constipated or if you don't go to the toilet on a regular basis and your habits are a bit erratic for whatever reason, then the stool tends to become hard, and also the process of evacuating becomes difficult, and people tend to strain, and that causes a congestion of the blood vessels, and the incidence of hemorrhoids in those patients are higher. Some patients don't have an issue with the consistency of their stool, but have gotten used to spending a lot of time in the toilet, and that is habitual. In the sense they read, or they use the time to think or something, but as a result they are in a position, their body posture as well as their muscle relaxation, their straining patterns are all prolonged, and as a result they also tend to have certain a higher incidence of having hemorrhoids. So the recommendations, as we probably discuss a little later, is that you spend a minimum amount of time in the toilet. 5 minutes probably would be the maximum. Try for 3. And I remember when we were medical students, one of our professors used to say, he specialized in colorectal disease, so he used to say that he had made up a system in his toilet where the bathroom light would switch off at 3 minutes, and that was to train himself to get the job done quickly to avoid these problems. So certainly it is not only your evacuation, but it's your habits, and the amount of time you spend in the toilet has a direct impact.
As you said, in a lighter note, people do tend to read and spend a lot of time. So without realizing, I guess, that it impacts on their health.
It does, yes.
And so that is something that I hope our listeners will take note of, and remember that you don't have to spend, or you should not spend, more than 5 minutes at the most in the toilets. So having said that, Doctor, maybe you can continue with the type of treatment. You did say how things can be sorted out in an initial stage, or without, as an outpatient, you said, in the clinic things can be done.
That's
procedures
right.
can be done to
Yes.
address the problem, but if it becomes further complicated.
That's right. So as I mentioned, the outpatient procedures would be the sclerotherapy and the hemorrhoidal banding, which are commonly done in Sri Lanka now, and it's freely available. And if the problem is bigger or more aggravated, the hemorrhoids are bigger, or the anatomy of the hemorrhoid is not conducive to any of these treatment methods, then we move on into options of surgery. So surgery, also the options available are quite varied. There are a large number of procedures which have come into vogue fallen out of fashion for various reasons of recurrence, pain post-operatively, and various other concerns. But generally, as a staple, the hemorrhoidectomy, or the open operation where you remove the hemorrhoid, is still one of the fallback operations that we have. But having said that, new equipment has come in, technology has come in, and there are things called stapled hemorrhoidectomy, the hemorrhoidal artery ligation, where you use ultrasound to pick out the vessels and tie them off, and now laser hemorrhoidectomy has come in. So all of these things are building on knowledge that we've gained over decades, and using technology to come and fine-tune the process. But all of these things require equipment. It's expensive, and not all of them have the same outcomes as the tried and tested operations. They work in certain niche groups, but you need to be broad-minded when you approach it, and that can only be done by a medical professional or a surgeon. So going into detail of each of those is beyond the scope of this talk, I think. But just something that I want to mention is that what we tend to keep operative or surgical options for hemorrhoids as the last option. We try and manage these as an outpatient with minimal invasion, and to a great extent we can do that. But we always have this as a fallback. Why we try to reduce the number of patients we take for surgery is that, one, it's a sort of resource intensive procedure. The patient then has to undergo an anesthetic, and it's an operative procedure. So all the complications and the risks that go with it, though they are very small, are there. It's not without any risk. So therefore we try our best to manage it with the lesser measures, and if we can't, we fall back on those measures. So we tend to select the patients based on the disease at hand, but also on the patient's ability to withstand certain elements. For example, if you have allergy to rubber, you can't apply a rubber band. If you are on any medication that thins your blood, say a cardiac, then you have to think about whether these options will cause an excessive amount of bleeding. So these decisions can, as I mentioned, be only made by a medical professional, and that is how it should be done, because otherwise the risk versus benefit cannot be properly assessed, and the most suitable option for the patient cannot be selected. So what we recommend is that patients should meet their doctor as soon as they have symptoms. Meet them early, so that we can go ahead with the minimally invasive options like sclerotherapy or rubber band ligation. If you wait for it to become a big problem, or later on you come in late, then surgical options may be the only things available, and they have their own set of risks. And one of the things with surgery is that there is a lot of patients have discussed with, either they have had the surgery or they have discussed with people who have had the surgery, and there is a lot of concern with regard to pain, because it's a sensitive area, whatever said and done. And patients are worried about pain during the procedure. They are worried about pain after the procedure. They are worried about how many days they'll have to spend out of work, and whether these things will come back. Is it a definitive cure? And all of those factors come into what goes on in a patient's mind. So I think this is a good time to discuss that also. So with regard to pain during the procedure, if we are doing, say, sclerotherapy, as I said, it's painless. The rubber band ligation is, there may be a little bit of discomfort, but no pain because of the anatomy there. The operation per se, during the operation, it is painless because you are under anesthesia. Either, generally we tend to do it under spinal anesthesia, where you are paralyzed below the waist, and we make it completely pain-free. Or some patients need a general anesthetic. There are times when you can do it on local anesthesia as well, but generally the process is pain-free. After the operation, after a hemorrhoidectomy, there was a time when pain was a significant problem because you're operating in that sensitive area. But now, with the modern pain control methods and options that we have, we get the pain under control fairly well. But having said that, after the operation, there is some element of discomfort, and you would probably need to be away from work for some time until you are comfortable. because if sitting for a prolonged period of time or driving long distances can become an issue. So what it varies from patient to patient, the size of the hemorrhoid, how much dissection we do, etc., and also the patient's tolerance to pain. All that factors in. But generally, it's a doable operation and process with regard to the patient. And there is concern amongst patients, if I don't have this done, will it turn into a cancer? The answer is no. Hemorrhoids don't become cancers, but as I said, we need to discuss some matters surrounding that.
So what is the sinister part there?
With regard to cancers,
no, you did say, doctor, that there can be something sinister if not addressed.
So if we because hemorrhoids are so common, say a patient comes with bleeding while passing stool, and you have a look and you see a hemorrhoid, okay, but if you say 70 to 80% of patients who come in there can have a hemorrhoid, and you see bleeding, you assume that the blood is from the hemorrhoid. But because it is so common, if there was a cancer above it and it was bleeding, you see the hemorrhoid and you would assume that it is from that and miss the cancer above. So in that sense, because the two can coexist, and because hemorrhoids are so common, it'll be quite prevalent. It is important for us in all patients who come with bleeding with the stool to assess above the hemorrhoid also, to make sure that there is nothing sinister above it which is causing the symptoms and being masked by the presence of a hemorrhoid. So generally, if a patient comes to me with a blood in the stool, I would have a look initially in the clinic with what's called a proctoscope. And we can look at the lower end of the anal canal and the lower end of the rectum, and we tell us, okay, that's clear, this is the hemorrhoid. But I cannot see anything further with that instrument. So for that purpose, we need to do what's called a flexible sigmoidoscopy, which is a flexible fiber optic tube with a camera and a light at the end of it, where we look at the colon for a distance of about 70 centimeters. And that too is done as an outpatient procedure. It requires you to empty your bowel, and once it's clear, we do this camera just to make sure that the left half of the colon is clear of any other problem which could have presented with the bleeding. I'd like to reiterate that the importance of that is to avoid missing something sinister above the hemorrhoid. So when your doctor says, okay, you have hemorrhoids, but we need to do this is the reason. To make sure that there is nothing sinister above it. And generally, it's a safe procedure. It's very commonly done. The risks are minimal, but the gain you have from that is quite significant, because if you pick up an early cancer or a cancer above it, then the treatment can be initiated then and there. Otherwise, if you miss it, you will treat the hemorrhoid, but either you will continue to bleed or the cancer will advance, or both. So it is very important to have that assessment done.
And how long is this procedure, the test that you do?
The sigmoidoscopy is fairly quick. If you take the procedure itself, it will be about 10 to 15 minutes. But from a patient perspective, from coming into the outpatients department, having what's called an enema to get you to empty the colon at the bowel at that same setting, that's the toilet, and then to having the procedure done and recovering and going home, it will be about an hour and a half. And there is no sedation required, no other medication that's required, and the patient can walk home or go home immediately. So it's a very safe and very sort of flexible procedure that can be done with a lot of gain for the patient.
You did say, Doctor, a while ago about the recurrence aspects. So could it recur?
Yes. So hemorrhoids occur, as I mentioned earlier, because not only because of a problem in the anatomy, it occurs because of your habits. So say you have a hemorrhoid and it's treated, but your habits remain the same, then you are straining, your stool is hard, you're straining against resistance, that problem will recur. So it is very important, therefore, once you had your treatment or even before that, to change those habits into a conducive form to have a easy evacuation. So that would mean, as I mentioned, the time you spend in the toilet, your regularization of your bowel movements, and also the increase in the amount of water you drink and the fiber intake to make sure that you have soft stool. And it's important to maintain that even after your treatment, because otherwise it will invariably recur.
Just a question, doctor. I mean, how soon after a procedure will a patient have a bowel movement, and would it impact on the procedure that has taken place? Would it impact on the person?
No. So there is no way to avoid a bowel movement. So we anticipate that. So certainly after the injection, sclerotherapy, or a hemorrhoidal banding, there is no problem at all. You can pass stool. That's fine. After a hemorrhoidectomy operation, there again there is a wound there, but the passage of stool does not cause a problem because of it's designed to accommodate that the passage of stool. But we tend to give a laxative soon after the procedure so that the stool is kept soft, so that there is no necessity to strain and there is no unnecessary dilatation or traumatization of that treated area to prevent any aggravation. So the laxative that is given after the procedure helps the patient a lot with regard to pain and comfort.
Just one final question. Time has caught up with us. I don't know how best you can answer this, but how long does the inner healing process take, or will it depend from person to person?
It will depend from person to person. Now the sclerotherapy, that the injection takes a matter of days. The rubber band ligation, by blocking off the blood vessels, the hemorrhoid will fall off in about 10 days. The hemorrhoidectomy, the healing can vary. It depends on a lot of factors, especially patient's condition, age, so many things. But you're looking at a recovery period of 2 to 3 weeks. But you should be back home immediately after the operation the following day, and back at work within a few days. That should be fine.
Doctor, your take-home message?
Well, first thing is there is nothing to be shy about having hemorrhoids, and it is important to present early. It is very important to have a proper systematic assessment by a medical professional and get yourself seen early rather than late. Don't fear the examination. It's a very private and discreet process. And whatever said and done, whatever options we have, prevention is the best option. So maintain your bowel habits properly. The time in the toilet should be minimized, and have a good fiber and a water intake.
Thank you, Doctor. And on that note of advice, we end this very interesting discussion on hemorrhoids and place on record our most grateful thanks to Dr. Kesara Ratnatunga, Consultant General and Colorectal Surgeon, Teaching Hospital, Karapitiya. Thank you so much, Doctor, for sparing your very valuable time, coming into Colombo to be with us on the program from Karapitiya and sharing your expert knowledge with our listeners. We certainly appreciate it.
Thank you. My pleasure.
My thanks also go to Achila Gunasekara for technical assistance. I'm Fatima Razikada saying good night and hoping to catch you next Monday same time on Views on Health.